actually. I should apologize to all attendees for the very late presentation at late night. I hope we can share our experience with you in this night. There is nothing to declare as regards this presentation. The objective of my presentation is to review traumatic pediatric knee injuries and to discuss the workup and treatment options, to discuss complications associated with pediatric knee injuries and surgical treatment. Of course, today, because of the purpose of time, we will focus on the bony injuries, leaving most of the ligamentous and meniscal injuries for another meeting, another presentation. Otherwise, we can spend the whole night in this presentation. The pediatric knee injuries that we are going to talk about today is distal femoral physeal injury, proximal tibial physeal injury, tibial tubercle avulsion, tibial eminence fracture, patellar fracture, osteochondral fractures, patellar dislocation. And as I mentioned, meniscal injuries and ligamentous injuries need a separate presentation because they have a long history, long treatment, and different views. As we are talking about in all the course, the pediatric orthopedic injuries, there is unique pediatric principles. The pediatric age group has faster healing, remodeling potential, which is extra-articular imperfect reduction acceptable in many cases, and lower chances of stiffness even with prolonged immobilization. The physis, which is the gift that keeps on giving, injury to the physis at the time of injury or due to treatment will continue to present problem until skeletal maturity. You should respect the physis as much as you can, limit manipulation of physis to 7 to 10 days, and in another literatures and other points of views, they have just mentioned that 5 days is more than enough. After 5 days, they don't do any manipulation, but others still good give a chance for manipulations until 7 or 10 days. When reducing 90% of force in traction and 10% in translation. The best physiological age assessment method is the Taylor staging. Distal femoral physis has significant and peculiar anatomy. There is popliteal and genicular arteries located posterior to the distal metaphyseal and capsule. Displaced fractures can compromise vascular flow. A similar situation as knee dislocations in adults. This type and this category of injuries more problematic in proximal tibial physeal injuries because the vessels there are more limited in motion, less roomy. Distal femoral physis is highly undulating. Fractures involving the physis have 30 to 70% risk of permanent growth disturbance. Distal femoral physeal fracture epidemiology, it's rare, only accounts for less than 1% of all fractures. The mechanisms may be high energy trauma, and what's upcoming and increasing nowadays is sports injuries, accounts for 2/3 of distal femoral fractures and commonly mistaken for ligamentous injury. Varus or valgus forces, hyperextension of the knee, physis typically fare under traumatic force before ligament in children. For the distal femoral physis to continue, physical examination, you will find effusion as any knee injury, soft tissue swelling, obvious deformity, complete inability to bear weight, tenderness over the physis as opposed to isolated medial tenderness for MCL, for example. Anterior displaced to hyperextension injuries cause patella to become more prominent and anterior skin often dimpled, and this is commonly mistaken for quadriceps tendon and quadriceps muscle injury. Posterior displacement can cause the distal metaphyseal fragment to become more prominent above the patella, and there is obviously inability to bear weight. This is one example of severe injury in the distal femoral physis, and this is, in my opinion, one of the emergency situations because of the issue of blood vessels in the posterior compartment, as I have just mentioned. Always consider vascular compromise, and don't hesitate to do Dopplex or even CT angio. It is knee dislocation equivalent fracture. You should perform and document peripheral pulses, compartment evaluation, ankle brachial index, ankle brachial index, and ankle to ankle index. Reduce emergency. If vascular compromise, reassess after reduction. CT angio if needed. Monitor for swelling. Distal femoral physeal fractures, associated injuries. There may be, although the severe injury is evident in the X-ray, it may be associated with other ligamentous injury, especially medial or lateral ligament injury, vascular injury, nerve injury, compartment syndrome. Radiographs should include anteroposterior and lateral, oblique views, contralateral comparison, stress X-ray to avoid missing those spontaneously reduced. CT helpful in evaluating fracture complexity. You should do X-ray for the hip to exclude associated fractures in the neck, which is not uncommon. MRI for occult injuries, ruling out concomitant ligamentous and meniscal injuries. Distal femoral physeal fractures have many classifications, but for the ease of application and from diagnostic and prognostic point of view, still the Salter-Harris classification is the gold standard. Most of them is 1 or 2 Salter-Harris. The displacement may be in the anteroposterior plane, vargas plane, or any combination. Treatment, closed reduction should be always tried and started with, and as I mentioned in the first few slides, not after the 7th day in some opinions, and not after the 5th day in some opinions. If you succeeded to obtain reduction of closed method under image, so we would put an immobilization with a cast, splint, brace, or our colleagues in the Elizarov may prefer to put an external fixator. Percutaneous bending is a controversial issue, but in my opinion, I always prefer to supplement fixation, even if it's apparently stable, by percutaneous bending. Screw fixation, especially in Salter-Harris 2 and 4. Open reduction is our choice. If there is failed closed reduction or interposition, the open reduction usually accompanied with plate fixation or screw fixation. And most of them is Salter 3 and 4, Salter-Harris 3 and 4 interarticular fractures. If we choose the closed reduction and casting techniques, it's for the undisplaced or stable after reduction. Remodeling is best in flexion extension plane. Don't manipulate after 7 to 10 days, and then other views after 5 days. Splint slight knee flexion. Partial loop bearing is started at the 4th week. Closed reduction with internal fixation, screws or plates. We splint and cast for 4 weeks with pins. Almost always supplement reduction with fixation. This is to prevent recurrent displacement and to get rid of the headache and nightmares. This is an example of Salter-Harris 1. This is the lateral view. Treatment. Closed reduction with percutaneous wires was sufficient to reach our goal, and supplemented by cast like we see in this X-ray. The neurovascular is intact. Options: anti-grade percutaneous beam fixation, avoid replacement into the knee joint to avoid compromising the articular cartilage and decrease the risk of septic arthritis. Try to get the K-wire away from the Provençat line and from the Physeal line to be out of the joint capsule. Retrograde percutaneous beam fixation is easier to place pins, like it's recommended burying them under the skin to avoid infection, and it should be removed at 6 weeks. Always supplement pin fixation with a splint or cast or external fixator. Typically 4 weeks, maybe 6 weeks, then remove the pins. It depends on the age, depends on the size of the patient. As you know, there may be a 10 years old child, which is almost adult, and a 14 years old child, which is looking like a 6 years old one. Distal femoral physis. Also, the second option after closed reduction is open reduction. The indications: fracture that cannot be reduced closed, or redisplacement after achieving reduction. This may be due to interposition periosteum or capsule or ligament, or muscle. Open displaced fracture or floating knee. Preoperative CT scan, especially CT angio, can assess and aids in surgical planning. Technical tips: the metaphyseal spike side will have almost always, intact periosteum, and an open fracture, the post side to remove the interpost, you have to open to remove the interpost periosteum, which is the cause of re-displacement. This is an example of Salter Harris 2 with a spontaneous reaction after direct injury in the 13 years old boy. Reduction in place, screws in place, screws inside. What are the potential complications? Here, the lateral edge of the growth plate is very close to the washers and screws, and this may cause irritation and may by itself cause complication like deformity or premature physical. Another example of Salter 2 fracture, reduction and screws. Sometimes, if the child is approaching maturity, we can use plates, and these plates may be locked or not the plate, and in my opinion, non-locked plate is enough and is cost effective. This is another example. Salter Harris 3 fracture, 15 years old male, football injury, valgus force to the lateral side of the left knee. This is a CT. No gross displacement. The risk of vascular injury still there, but less than the previous types. But the problem in such fractures, the fracture may have been more displaced, and spontaneous reduction or trial of reduction in the scene promotes the child to this fracture. So CT angio is always a better choice. Screw in situ, which is removed later on, maybe 12 weeks, open reduction and internal fixation. One of the technical tips is the hardware should remain anterior to the prominence line when passing in the intercondylar notch in the anteroposterior view to remain out of the joints. This is a common mistake. To pass in the joints if you choose one plane only and if the image is not that clear. Obtain notch view of the distal femur to confirm intraosseous extra-articular placement. Of distal femoral physeal fractures, the risk of damage to growth plate and growth disturbance is always there. Minimal manipulation and avoid manipulation after the 7-day. Growth disturbance is likely to occur in younger patients with fractures that are displaced more than half the diameter of the shaft. Check the rig length, alignment, and gait at 6 months. If you put hardware, it's better to be removed at 3 to 6 months. Managing the rig length inequality, if less than 2 centimeters at skeletal maturity, non-surgical management. 2 to 5 centimeters appropriately timed apophysiodesis of the contralateral leg. More than 5 centimeters leg lengthening should be considered. Angular deformities is managed by properly planned osteotomies or hemiepiphysiodesis approaching skeletal maturity. Major complication is growth arrest. Initial injury after cortical reduction may look so innocent, but it may reflect or may hide a growth plate injury, which will show its impact later on life. Yearly physeal closure due to screws. Growth arrest in the same child after 6 months with leg length discrepancy. So there is one subtle injuries. This is an 11-year-old male with right knee pain immediately after being tackled in football match. There is minimally displaced Salter Harris 1 distal femoral fracture managed by missed by the ED and radiology. With follow-up, physeal arrest noted, expected a significant discrepancy because 5 years of growth is still remaining. The next fracture is this fracture epidemiology. It's rare injury, less than 1% of pediatric injuries, the mechanism high energy trauma. Varus or valgus force, hyperextension. The physical examination is not much different from the previous one. Proximal tibial physeal fractures may be associated with compartment syndrome, may be associated with vascular injury. We mentioned before that the blood vessels in the tibial side have less room to move and less pliable and less forgiving for displacement. It can present with and significant swelling and vascular injury and compartment syndrome, which is much more important than the fracture and the growth. Proximal tibial physeal fractures may be associated with other injuries, like PCL injury, like medial or lateral collateral ligament injury, like patellar or extensor mechanism injury. The possibility of vascular injury here is much more common than the previous one, and also the compartment syndrome is much more common. AB and lateral X-rays is important, but always remember that the picture you see is not necessarily the picture that started at the time of injury. So don't hesitate, if in doubt about blood supply, to do CT angio. MRI is not frequently asked for and does not have much value except for cases you suspecting associated ligamentous injury. The treatment of proximal tibial physeal fractures may be closed or open. If you choose the closed with minimal displaced fracture or reduced fracture, or you succeeded to obtain reduced stable fracture, immobilization either in cast or splint. Fixation may be with pins in younger patients. Transphyseal pins, especially smooth, non-threaded ones, is good. Internal fixation with screws in Salter Harris 3 and 4. If there is metaphyseal fragment, even plates can be used. And as I mentioned before, it's preferable here to use non-locked plates. Open reduction with similar fixation option. Closed reduction and casting is used in non-displaced stable fracture, neurovascular intact, splint and slight knee flexion for 4 to 6 weeks. Closed reduction with internal fixation is used for those failed to be reduced or unstable after reduction. Fixation should be parallel to the physis, smooth pins or cannulated screws. Splint the knee in slight flexion and splint for 4 to 6 weeks. "14 years old, basketball player, landing from a jump. Note the step of, I don't know, it's clear, sorry. There is a step of posterior.
It's clear, sir. It's clear, sir.
Step off posteriorly from the epiphysis to the metaphysis. This type of injury in the lateral view, epi view, looks so innocent. But if you look in the lateral view, there is displacement of the proximal part of the tibia related to the distal part. So this one of the commonly missed injuries, which sometimes is not declared, not diagnosed except after CT or MRI. This is after reduction and fixation by pins, smooth, non-threaded pins, then cast or external fixator. If you are in doubt about any vascular injury or compartment syndrome, don't hesitate for fasciotomy. Open reduction and internal fixation for proximal tibial physeal fracture. If you did not achieve anatomical reduction with both methods, if there is interarticular fracture that cannot be controlled or reduced, internal fixation with the screws parallel to the physis, K-wires cross and traversing the physis, smooth, non-threaded, crisscrossing. Splint with slight flexion, typical post-operative progression with cast for 4 weeks, then remove pin, partial repairing is started yearly, and full range also is encouraged here. Another example, 10 years old male with this injury after football match, hyperextension when he is tackled. The prominence in the posterior part is very dangerous for the popliteal vessels, whether as an acute vascular injury or as a delayed compartment syndrome. DVT is not uncommon in such cases. This patient has underwent closed reduction with percutaneous K-wires and 4-compartment fasciotomy for compartment syndrome. And luckily enough, passed, alhamdulillah. Luckily enough, passed good, yani, not passed away. Complications, he developed, unfortunately, a proximal growth arrest and physeal bar, which need later on lengthening by Elizabeth. The outcome and prognosis is good in most cases if managed early, as long as you put your eye on vascular injury and compartment syndrome. Shortening and angular deformity is less common because these fractures occur in older children and because the proximal tibial epiphysis contributes less to the growth than femur. Open injuries coincide with poorer prognosis and more likely to have angular shortening and deformities, whatever you do. The next tibial fracture. This is epiphyseal in some literature and apophyseal in other literatures. This is the cartilaginous stage through 9 to 10 years. Apophyseal stage, ossification center 8 to 14 years. Epiphyseal stage, the ossification center of tubercle and epiphysis as one mass 10 to 17 years. Bony stage, the physis is closed between the tubercle and the metaphysis. 98% male, it's male predominance, and the common age is 12 to 17 years, and this is very common in football and handball players. Active quadriceps extension with knee flexed, jumping or sprinting. This is a physical picture, which is not different from the proximal tibial fractures. There is a skin blanching, and there is a compartment syndrome is still not uncommon. AB and AAs are usually diagnostic. Slight internal rotation of the tibia should be done in the lateral tray especially. It's differentiated from osseous lateral disease by the history, the severe tenderness, and the degree of displacement. Advanced and MRI is usually not needed. This is an example. CT showing an intercalary depressed fragment. It's important to know preoperatively. It's important to know the age. It's important to know the duration from injury. This injury actually came a little bit late, and although the reduction fixation was good, but the prognosis was not that good because the management was delayed for about 1 week. Classification of tibial tubercle avulsion fracture by Watson-Jones, modified by Ogden. Type 1 fracture to the tubercle apophysis. Type 2 to the apophysis that extends between the ossification centers of the apophysis and the epiphysis, and this is typically at 7 to 8 years. Type 3 fracture to the apophysis extending across the epiphysis, 4 and 5, which is known as sleeve fracture. Treatment, close reduction and casting versus open reduction and internal fixation. And in my opinion, for the sake of the extensor mechanism integrity, open reduction with percutaneous cannulated screws fixation or open cannulated screw fixation is a very good option in such type of fractures. This is an example, 15 years old male playing basketball, landed awkwardly on the left leg from a jump shot. This is the MRI picture. And this is the treatment, open reduction, internal fixation, cannulated screw, yearly rehabilitation, yearly return to sports. He can catch the next season. Another example, which is more severe injury, provisionally extend the leg, immobilize an extension to reduce the skin traction and to decrease the risk of skin complication, which is very common in such type of fracture. After doing this maneuver, before going to OR, do CT to reconfirm and check how many fragments you have. Cannulated screws above and below the growth plate parallel to the physeal line. Type 4, tibial tubercle fracture, 15 years old, football player, severe pain, with planting leg, decelerating to change the direction. There is posterior metaphyseal extension, so it should be managed operatively with open reduction, internal fixation, and this type is very amenable to develop delayed compartment syndrome. Because this child is approaching skeletal maturity, we have the courage to put this plate with the small screws and the other anteroposterior screw to get for the posterior fragment. Another example, another match. The outcome is usually good with internal fixation. Closed reduction without internal fixation usually don't go for good prognosis. There is risk of skin complication. There is minimal risk of possible growth disturbance and possible loss of flexion secondary to stiffness. Patellar fracture in children is not that different from adults. This is a 6-year-old female, fall directly on the knee while playing basketball. Such degree of displacement, as we all know, usually reflects retinacular injury with the knee, with the bony injury. Physical examination and radiograph is classic. The classification with Grosjean 1990. There is depends on the ossification center and the number of fragments. There is primary osseous fractures. There is avulsion fractures, whether superior, inferior, medial, with lateral displacement, lateral with medial displacement, which is equal to injuries of the medial and lateral patellofemoral ligaments and others. Sleeve fractures through the cartilaginous cap on the inferior superior bore of the patella, easily overlooked, little amount of bone, large amount of cartilage, usually need MRI for diagnosis, assess for palpable defect at the affected patellar pool, and there is loss of active knee extension with localized tenderness and ecchymosis at the injury site. Treatment, close the treatment with casting if the fracture is not that placed so much like the previous example. If such displacement is present, so open reduction internal fixation is necessary. Don't forget to repair the retinacular injury. Open reduction internal fixation may be in the form of tension bands, circumferential wires, and I prefer to use non-absorbable sutures rather than circumferential wires in such injuries. If there is 3 mm displacement at the articular surface, suture alone could do enough treatment for sleeve fractures. Always remember, retinacular injury splint for 4 to 6 weeks. The outcome, according to the UNET, good prognosis, no complication if managed yearly and properly. K-wires, sometimes cannulated screw, but K-wires in children is usually enough. Tension band here is done by braided non-absorbable sutures, which have less complications and less liable to break if it's compared by stainless steel tension circulation. Interarticular fractures in children associated with massive hemoarthrosis, 50% chance of traumatic ACL injury with it, can be due to tearing any vascularized interarticular fracture. It may be osteochondral injury, meniscal injury, ACL, PCL, avulsion, patellar fracture. If X-ray is negative, don't hesitate to request for MRI. Tibial eminence fracture, usually discussed with ACL injuries, but I will go through rapidly in this presentation. Usually, children is 8 to 14 years. Before ossification is complete, the surface of tibial spine is cartilaginous. With excessive force applied to the ACL, the spine offers less resistance than ligament, and if the injury is at the cartilaginous level only, it's very deceiving and usually needs good MRI correlation and good MRI observation to detect such injury. The mechanism, rapid deceleration, forces that would lead to ACL tear in adults lead to tibial spine fracture in children. Physical examination is classic and typical. Mayers and McKeever classified it into type 1, non-displaced, type 2, displaced, and type 3, completely displaced. There is another classification, classifying it into 4 grades, putting the cartilaginous only as type 4. Treatment, reduction with evacuation of hemoarthrosis, above knee immobilization, and operative treatment, in my opinion, especially in professional athletes, is a must. Tibial eminence fracture, to be detailed later with ACL injury if we have time and chance to give this presentation. This is another one example. We'll go through rapidly. One example. Avulsion from the tibial side, fresh injury, prognosis if managed early. Osteochondral fractures other than tibial eminence fracture, epidemiology, 5% of all acute patellar fracture and less than this percentage with femoral and tibial sides. Assume osteochondral fracture is always present until you prove it is not with careful MRI review, which will hide in plain X-rays. Physical examination, the very spectacular and prominent is the severe hemoarthrosis in such injury and may be looking. Treatment, surgical excision if it's only cartilaginous or pure cartilaginous. Some try to preserve it with headless screws and biodegradable screws, but the prognosis is not very encouraging. This is one example. This is traumatic, not like osteochondritis secans. Another example, cartilaginous only, cartilaginous part removed. This is our colleagues that try to fix it with headless screws, but the prognosis is not always good. X-ray post-operative, and this is after 3 months post-operative with second look arthroscopy. Patellar dislocation, usually discussed with patellofemoral instability. Like I mentioned before, it may be bony, it may be sleeve, it may be ligamentous injury. Surgical treatment, like the treatment of patellar dislocation, like the treatment of MBFL in others. Should do long film or CT scanogram to exclude that the patient is predisposed to such fracture with angular or rotational deformity, which should be corrected to avoid recurrence. Meniscal injuries in children is a long story and needs separate presentation, but rapidly repairable meniscus in children should be repaired. Sutures is better than all insides. Fix them well. Zones are somewhat different. Vascularity is more approaching to the inner side. Avoid over-suturization and discoid meniscus to avoid inducing iatrogenic instability. Don't miss root tear even in children. This is a combination of ACL and bucket handle tear. And this is ACL injury. Pediatric ACL injury is not discussed in this presentation. Common injury, ligamentous injury, and it's also classified with a KD classification like knee dislocation and others. The treatment reduction with neurovascular examination before and after, and don't hesitate again to request for CT angio, knee immobilizer, or even knee fixator in extension, or slight flexion. Operative if there is an unstable knee with ligamentous injury, external fixation for stability if vascular repair is required. PCL is extremely rare in children. In the study by Kocher 2012, 26 knees age 18 and under, 15 of them treated operatively and 11 non-operative, and 95% good to excellent outcome in both groups. This is the article treatment of posterior cruciate ligament injuries in pediatric and adolescent groups, and the conclusion was there. Outcome for non-operative treatment of partial PCL tears or non-displaced avulsion injuries are good in young children. PCL repair or reconstruction is safe and viable treatment option in pediatric and adolescent patients with multi-ligament injury or those with isolated PCL injury who have failed conservative treatment with outcomes related to the severity of injury. The problem in this study, it does not categorize the patient whether they are professional athletes or they are non-professional athletes and put all of them in one group, which makes this study and its conclusion a little bit weak. PCL with tibial physis, PCL insertion midpoint in the proximal part of the tibial physis in all cases are proved by MRI. Some fibers may extend distal to the physis in older age, 17 and 18 years. This is the approach of tunnels. You have to go the tunnels with a little bit lower than usual with PCL reconstruction. PCL injury in children, in conclusion, although rare, direct repair is feasible, and reconstruction, especially if associated to multiple ligamentous injuries, is a very good viable option. In summary, pediatric knee injuries present unique challenge due to the physis. Monitor for neurovascular injuries and compartment syndrome. Be aware of skin compromises in tibial, tubercle, and tibial tuberosity injuries. Pediatric patients have a lower chance of stiffness. Fixation can be supplemented with immobilization. Articular injuries in kids still require anatomical reduction. Avoid crossing the physis with fixation unless near the skeletal maturity or using the small diameter smooth provisional ends. And this is my references. Thank you very much.